Amanda with Straightsmile Solutions, straightsmilesolutions.com, and today we're going to talk about VME, or vertical maxillary excess. And I'm going to tell you a little bit more about how to identify it and maybe how to manage it. For the most part, the management is surgical in nature for ideal. I think if you catch it much earlier, sometimes you can interfere and do some management so it's not quite as bad. There's definitely some interdisciplinary management you can do to make things look a little bit better, but we used to call it in residency, and I know that I didn't used to call it, but people called it horse face, because basically you see this, you see that, you see that. I mean, I'm sure if we got cephalometric x-rays on these two stock model photos, they would have VME. They're just classic VME looks. I just happened to find them on Shutterstock as good examples of VME. Once you see it, you can't unsee it. So there is definitely some literature about it, about VME, and how to identify it. We can definitely go over that a little bit. I've got one from a journal called Ortho, and they're basically calling it long face syndrome. So they're saying it's a clinically recognizable facial morphology. A long face syndrome is manifested by excessive lower vertical facial height. And there's an open bite type and a closed bite type. And there's two different types. Not everyone who has VME has an open bite, but those that do have an extreme clockwise rotation, high angle case, adenoid faces, idiopathic long face, total maxillary alveolar hypoplasia, and vertical maxillary excess and excessive vertical growth of the maxilla. Okay, so I believe, this is just my personal, and I couldn't find any literature on this, but I do believe that if you catch this in a kid, a lot of times it might have to do with airway. I mean, I'm not sure, but I mean, it is a similar growth pattern. So I would imagine, and these adults usually have very narrow arches. So I'm thinking that if you intervened with phase one, you might be able to reduce how things look as an adult. And definitely as an adult, if the patient didn't want to have jaw surgery, and I have done one of these jaw surgery cases. I didn't do the surgery, I assisted with the surgery, but I did the pre-op ortho and the post-op ortho. Came out amazing, but I do remember we had to fracture the maxilla, down fracture, expand the maxilla, impact the maxilla, and then the mandible auto-rotated. But it was a pretty gory procedure. So I do definitely remember that. But I mean, a lot of times these jaw surgery cases are going to get covered by insurance too. So I mean, I think it's definitely worth checking in. I mean, a lot of times patients are like, I don't want surgery, but you got to get the information, because what if it is covered by insurance? And what if this can give you a better lifespan and a longer life? I mean, it's worth trying, getting the information at least, right? I think you kind of have to do that. But I've treated these cases just orthodontically. I mean, it's going to be a combination of periodontal surgery, probably now that we've got neurotoxins for the hypermobile lip, bringing that lip down, possible lip repositioning surgery. The thing is, none of those surgeries are going to be covered by insurance, most likely, but a jaw surgery might be. So I mean, they're going to end up spending a lot of money on things just to camouflage it. So why not just get the surgery and hopefully it's covered? But that's just my thought. Orthodontically, of course, very difficult to close an open bite in an adult if you have one. But if you catch this kiddo, while they're growing, I mean, maybe send them to ENT, send them to OMT, expand the arches, get the airway better, and improve breathing. And it may not be so bad as an adult. That's my thoughts. All right. Thanks so much.